This is the perfusion lecture number 1. First, we're going to go over pathophysiology and management of arterial disease. So basically, the etiology of arterial disease is an injury to the vascular endothelium. This injury can be caused by smoking. Smoking basically is causing inflammation. It also causes vasoconstriction. That's what nicotine's action is on the veins and arteries. So smoking, they must stop. Diabetes mellitus basically causes the endothelium to be inflamed, to attract more particles. To decrease this, we want our hemoglobin A1C to be below 5.5%. And you know our hemoglobin A1C, it basically is a report card for diabetes. It lets us know how the blood sugars have been running over the last 3 months. Injury can also be caused by C-reactive protein. This is produced in response to inflammation. Our goal is less than 1. And also homocysteine, which is an amino acid that our body makes, and our goal for that is to be less than 12. So we have injury due to inflammation or some other cause. This causes an overgrowth of the intimal layer with macrophages. So basically, cells from our immune system start building up in our arteries. Then they create a matrix of connective tissue, and then lipids, collagen, and cells will accumulate in that matrix. We have arterial diseases, and here are the 3 categories. So we have coronary arteries, and within that, the disease would be called coronary artery disease. They can have angina and myocardial infarctions because of coronary artery disease. And then peripheral artery disease is collections of those cells in the peripheral arteries. One of the signs is intermittent claudication. So basically that's intermittent obstructions of blood flow to the extremities. Carotid and cerebral arteries, that would be cerebral vascular accident, or CVA, or stroke, or transient ischemic attack. And that's like the one that's intermittent and it passes through later. CVA, it means it's blocked and it doesn't get re-oxygenated after that point of blockage. Next, we need to memorize the fat metabolism lab values. So total cholesterol goal is less than 200. Our HDL, our healthy goal, is greater than 40 in males and greater than 50 in females. Our LDL is less healthy type of cholesterol, and our goal is less than 100. So we can do less healthy, LDL. Healthy is HDL. So that's kind of a way to remember those. And then triglyceride goal is less than 150. And here's also a chart that shows that. So we need to know the diet changes necessary to reduce or maintain the healthy cholesterol levels. So we want to eat a diet low in saturated fats and high in fiber. So saturated fats tend to be processed and there's more cholesterol in our blood, or the bad kind of cholesterol. And soluble fiber, what fiber does is it helps move food through our system so it has less time to absorb the fat. So that's why those are kind of a double threat and really help. So like foods that are high in cholesterol, we need to know those. So they're fried and red meat. So basically animal fat is a good way to remember it. low intake, or the low items are high in fiber, and then they have good fats like salmon, olive oil, and nuts. So when do we give a patient medications when they have high cholesterol levels? So they're usually started when they have already had a heart attack or stroke or have peripheral artery disease. A patient's LDL cholesterol level is 190 or higher, or a patient is 45 to 75 years old with diabetes and an LDL cholesterol of 70 milligrams per deciliter or higher. HMG-CoA reductase inhibitors, that is simvastatin. It inhibits the enzyme needed for lipid synthesis. We're going to monitor liver function. So you can tell that we're going to want to monitor liver function in most all of these, because that's where these drugs are working on. We synthesize and change fat in our liver. So that's where all these drugs are activated for. So we have, they also can have signs of myalgia, which is body aches. It's more important to give this in the evening. Next is nicotinic acids, or niacin, and we want to also monitor liver function. And it also can cause GI upset. Then we have fibric acids, or gemfibrozil. We want to decrease, it decreases the synthesis of triglycerides, so we're going to monitor the liver function. Bile acid sequestrants, cholestyramine, it also decreases the fat absorption, so it basically is going to increase passage of fat through the stools. And you want to take this with meals because it basically blocks our ability to absorb the fat in that meal. Cholesterol absorption inhibitor, and it inhibits GI cholesterol absorption. And then omega-3 fish oil, it'll inhibit triglyceride production. Ways to reduce cholesterol would also to include having a BMI of 18 to 25. That's everybody's goal, and it should be done through diet and exercise. We want to make sure everybody is at least 30 minutes a day, most days of the week, of activity, and that could be low impact like walking, swimming, or it can be running, aerobics, but at least 30 minutes of activity a day. A lot of doctors recommend steps because everybody has step trackers now, so at least 4,000 steps a day would give you maybe 30 minutes of activity. So acute coronary syndrome is the first diagnosis we're going to talk about, and we need to differentiate stable angina versus unstable angina. The first thing you know about stable angina is it's brought on by exertion and it's relieved by rest. Unstable angina can happen out of the blue. It doesn't have to be precipitated by activity, and it lasts more than 30 minutes. It's a long standing problem. So angina is caused by coronary artery disease. There's a partial obstruction in angina. It will cause areas of ischemia. So it's just reducing the blood flow to the heart muscle from a narrowing of the artery, and it can cause angina. So, but a complete blockage would be an MI. So in acute coronary syndrome, you can have two things. The first one is your unstable angina. That's the angina that happens out of the blue. It's not associated with exertion or rest. It can happen during rest and without provocation. It's caused by CAD worsening or partial obstructions. changes in the ischemic pattern. And then we have MI, which is where a plaque ruptures and a thrombus is formed. It goes down the coronary artery and causes occlusion, cell death, and then eventually a scar in the muscle tissue. There's 3 zones of change in an ECG. The first one is our infarction, causes necrotic or dead cell formation or scars. This will cause a Q wave change, and the Q wave will become extra wide. Number 2 is the ST segment. This is injured but not yet necrotic, potentially viable tissue in the muscle of the heart. It also is the difference between a STEMI and a non-STEMI. So a myocardial infarction does not have to have ST elevation, but when it does represent a STEMI. So that is ST elevation MI versus a non-ST elevation MI. And then we have the T wave inversion, and this is just showing that there is ischemia and oxygen deprived cells in the heart. So the most common locations for blockages in the heart is your right or inferior coronary artery. It supplies blood to the right side of the heart, the SA node and the AV node. And when we have an MI there, we see conduction abnormalities. Then we have the left anterior descending or LAD and the anterior and septal area, and that is our anterior AV septum bundle branches. That's what gets deprived of oxygen, and the anterior and lateral left ventricle. Then we have complications with that one. It's called the widowmaker. It often causes fatal MIs. We will have intraventricular conduction defects, heart failure, and lethal dysrhythmias. Then we have the circumferential and lateral artery. It will supply blood to the left atrium, the posterior and lateral left ventricle. So here's just this over again. The RCA supplies the right side of the heart, SA node, and AV node. The LAD supplies blood to the AV septum, the anterior left ventricle, and the lateral left ventricle. And then the circumflex and lateral supplies to the left atrium and the posterior wall of the left ventricle. So important things to know, atherosclerosis is the deposit of plaque in the vein, or in the arteries, and coronary artery disease, these are all the risk factors for these diseases. So they're going to have a high cholesterol level, especially the bad LDL cholesterol level, and they will have a low HDL cholesterol level. Generally, high blood pressure is a big risk factor as well. Family history of heart disease, diabetes, smoking, being over the age 45, if you're a male or a postmenopausal woman, if you're overweight, if you're physically inactive, and then if you're an African American, Mexican American, Native American, and Native Hawaiian, or an Asian American, have increased risks because of the higher rates of high blood pressure and obesity and diabetes in these populations in the U.S. with our U.S. diet. So what are we going to do? We're going to ID the pain. Where's the source? Is it going to be a cardiac kind of pain, or is it GI? If it's angina, it usually radiates to the left arm. It's upon exertion. or stress, nitroglycerin, and rest fixes it, and it lasts less than 15 minutes. If it's an MI, it's going to radiate to the left arm, back, jaw, has no cause or warning. It usually happens in the morning. Opioids help the pain. It's going to last greater than 30 minutes, and it's also associated with nausea, diaphoresis, dyspnea, fatigue. They have the fear and anxiety, so that impending doom feeling. They're also going to have dysrhythmias. Atypical signs and symptoms. So older adults with diabetes mellitus will have neuropathy. So they won't feel the pain because neuropathy doesn't just affect your hands and feet, it's your whole body. So they may have what we call a silent MI. Women, 50% have fatigue, back pain, and shortness of breath. So it doesn't really fit the typical assessment of MI. With elderly, dyspnea and confusion are the most common symptoms. So that might be kind of hard to detect. Older adults have more collateral circulation for the coronary arteries. Therefore, an MI may be more lethal to a younger person. So we do grow more supporting arteries as we age. And you might see that the elderly population has kind of spidery veins. They also have spidery arteries. They're harder to see. But we do that on our heart as well. So they have collateral or extra highways for blood compared to younger people. Therefore, they are not as impacted by MIs as much as younger people. So this is a 12-lead EKG paper, and we're going to learn more about what the different areas are viewed from and where it's detecting the electrical current from the heart. So the basics are, it is a 12-lead, and that's another word for view, EKG. So let's get away from calling the things we stick to their chest leads, and let's call those electrodes instead, and I feel like we'll understand it more. So there is, so the leads are actually the views. So limb leads or views versus chest leads or views. So there's 6 of each. So there's 12 leads from, or 12 views from actual 10 actual. Lead 1 or view 1, it's the first box on your 12-lead EKG paper that prints out, is the view from the right arm to the left arm. And this comes directly from the left and right limb electrodes communicating to each other. Then lead 2, this is view 2, is what it really is, and it is it's one of the limb leads. It's shooting a direction from the right arm to the left leg. And then lead 3, or view 3, it's the third one down on the EKG paper. It's viewing from the left arm to the left leg. So basically 1, 2, 3, VR, VL, and VF are all coming from electrodes that are stuck to the arms and legs. The chest electrodes are V1 through 6, and that's the next 6 boxes on the EKG. Here are the positions of the electrodes, and then in the muddy points I have posted a little video on how to do a 12-lead EKG. This is just another view, so it kind of ties together the two things. We were talking about where the injury is to the heart and what leads we're going to see it in, and then this also shows you how the views are also done. And then this is just a review of how the electrical currents are running through the heart. You know, we have the SA node and it goes to the AV node, and then it goes on the way down to the bundle branches. So as you can see here, we have view 1, 2, 3, AVR, AVL, AVF, and those are all coming from our limb leads, which is our right and left arm and our right and left leg. And then V1 through V6 are the electrodes on the chest. And then at the very bottom, it has a rhythm. So this is just basically, usually it comes from just the rhythm, like a telemetry rhythm. And it's also included, but it's not always there on every 12 lead EKG. And then this just describes that as well. So we need to know that 12 lead EKGs are tests that identifies locations of MIs. They're more in depth than just cardiac monitoring, because this is just a test. It's not a continuous way of monitoring patients. So inferior MIs will have changes, ST elevation, and 2, 3, and AVF. Okay, so ST elevation, we know it comes directly off the S and it goes into a T, and it does not go down to that imaginary isoelectric line. And in anterior, we're going to see ST elevations in V2, V3, and V4. And lateral, we'll see it in AVL, V5, and V6. And then you get to check yourself here. And here's the answer. And you have to check yourself here. And here's your answer. And here's another one. And this is septal. So this is the fourth one you need to know. You will have elevations in V1 and V2 with a septal MI. So there's 4 kinds you need to learn. And here is, again, a nice little chart that you can help you remember that. So this is just an interesting fact that So for this slide, you need to understand that the biomarkers or the blood tests for an MI. So the first one we need to know is troponin, and the next one is the CK-MB. Basically, they're detecting markers that there's damage to heart muscle, okay? And so they both start to rise 3 to 6 hours after an MI starts. So that's really, really important. That's what we need to know. You need to know your lab values here. So our chest pain, our goal is no pain. We do not want them to have any chest pain, right? So we're going to treat them till the chest pain is totally gone. So with nitroglycerin, we're going to do a pill every 5 minutes, taking blood pressure in between, and we're doing it 3 times total because our goal is 0 pain. Now, if they have no pain, if they have pain afterwards, we can pretty much comprehend that they're having an MI, and it's not just unstable angina. So that's when the morphine comes in, and we will start giving morphine. I do have more clarification of this in the muddy points. And then we have oxygen that we're going to give, and we have aspirin we're going to give. These are all the drugs that we do immediately. And what this combination of therapy does is it decreases myocardial oxygen demands, and it increases myocardial oxygen supply. That's our goals. Post-MI. So we're still going to continue with aspirin. The patient will be placed on a beta blocker. They may be placed on a calcium channel blocker. because that helps dilate the coronary arteries, and it decreases the myocardial contractility and the demand for oxygen that's needed. Clopidogrel and aspirin are our platelet, we decrease platelet aggregations, so that helps prevent further formations of thrombuses. So if they have it happen once, it's probably going to happen again. And then statins, we want to start one of those because we need to reduce their cholesterol levels. So we're going to start with muddiest points. I had one that just said EKG interpretation. So I'm not really sure the specific question about that. I can only point you to the resources. This is a topic you really need to be going over in clinical as to how to interpret. And I have voiceover PowerPoints in my EKG module, and there is also practice packet inside that module. But I really recommend that you're practicing measuring and interpreting. Those are two different steps. Measuring always has to come first, and interpreting comes second. That you're doing that every week in clinical. And your instructor and your clinical instructor should be going over this with you every week. If you're needing extra practice, you can go to the EKG link sites that are in our library site. And for even more practice, consult your nurse that you're working with that day. See if they can help you understand how to interpret their patient strips. Most PCUs do at least twice a shift, and so I expect you guys to be printing off several strips per day. Next one is EKG lead placement. So here's a video that will show you how to place them correctly. And here is a slide that will tell you exactly where to put V1 through V6 because those are the most complicated. The ones that are for your arms and legs, those are pretty easy to figure out. And then muddiest points, here's just another slide that you can read to talk about MONA, order things should be done. Generally, it's nitroglycerin is given prior to morphine because we don't really want to mask the pain. We want to make sure the nitro's eliminated the pain. And if it hasn't, then we kind of implement the morphine sulfate. Oxygen, we're going to give that to make sure their SaO2 is greater than 92. We need them to have plenty of oxygen because obviously they have an oxygen deficit in your muscle tissue. Then here's a question. What's the difference between view and leads? So views are leads on the EKG printed paper. Electrodes and stickers are also commonly called leads, so it's very confusing. So that's the confusion. So when we're interpreting the 12-lead EKG, it's really taking 12 views from the heart, but only uses 10 electrodes. So I'm going to try to say, if it's a sticker on the body, I'm going to use the word electrode from now on. Muddiest point. What are the different types of MIs we need to know how to interpret? So there are the four. Anterior, inferior, and septal. So the one slide is what I had earlier. And then I found this other one, and it even tells you what coronary artery is blocked. So that's kind of fun. And then, what is the difference between telemetry and 12-lead EKG? So cardiac monitoring or telemetry uses 3 to 5 electrodes, that's the stickers, to view the heart, okay? And this is good for continuous monitoring. You can view it on a monitor or from a telemetry station. It's not as specific as EKG because, as you know, there's artifact and people are moving. So it's not necessarily as specific or as sensitive. There's placement differences, and I put the little rhyme here so you know how to change the electrodes at the hospital. So right side, it's clouds over grass, so that's white over green. Middle is chocolate is close to my heart, so it's brown. And then left side is the smoke over fire, which is black over red. So I always remember heartburn, so the ones that are associated with fire are over the heart. So that's how I remember where to put them. The next one is EKG. It uses 10 electrodes to get 12 views of the heart. A patient must be still, and it's a test that takes about 2 to 3 seconds to upload in the machine. It takes longer to put all the stickers on. And it's a more detailed, shows more detailed problems of the heart. And the placement differences is it uses 12. And these, I have a little picture of where they're placed, but it's not that great. It's more in depth in our video. Okay, Muddy's point. What do we need to know from the first video? So the one where I showed you that the coronary arteries and so forth and how they fill. So basically, know where the different coronary arteries are and what areas of the heart they supply blood to. And they also have a chart of the ones that you need to know. It also showed you the difference visually from angina and MI, and that was a really nice picture. So those are the things you need to know. Do we need to memorize the chart on slide 42? And that's the one that had the troponins and CKB, and the answer is no, but you do need to know lab values and at what point in an MI you'll see the increase of those lab values, and that is 3 hours. And remember that those tests are usually done every 6 hours times 3.